Hello everyone, I am Suneera and a second year DAMIT student from Sri Chitra Tirunal Institute of Medical Science and Technology, Kerala. Today I am here to present on the topic epilepsy imaging. First of all, what is epilepsy? Epilepsy is a chronic neurologic disorder that is characterized by spontaneous and recurrent seizures. The seizures are mainly caused by excessive and abnormal electrical discharges from the cortical neurons. Of the epilepsy patients, 70% of the patients are well controlled by drugs, where the remaining 30% are resistant to anti-epileptic drugs, which is known as refractory epilepsy. The only effective treatment for refractive epilepsy is the surgical resection of epileptogenic focus. The goal of epilepsy surgery is to remove or functionally disconnect the epileptogenic cortex that is responsible for the generation of seizures. Medically, refractive epilepsy is a social, economic, and medical burden. The most common entity associated with refractory epilepsy includes hippocampal sclerosis and the mesial temporal sclerosis. Classification of epilepsy. Epilepsy is generally classified into generalized epilepsy and partial or focal epilepsy. Generalized epilepsy originates simultaneously from both cerebral hemispheres, whereas the partial epilepsy originates from a localized area of brain. The partial epilepsy is again classified into simple epilepsy and complex epilepsy. The simple epilepsy occurs without any loss of consciousness, whereas the complex epilepsy occurs with loss of consciousness. The focal epilepsy can be categorized into 5 groups, which includes hippocampal sclerosis, malformation of cortical development, neoplasms, vascular abnormalities, and gliosis. Whereas the generalized seizures is classified on the absence of seizures, that is sudden cessation of conscious activity. Tonic seizures that involve stiffening and contraction of muscles. Clonic seizures that involves the area of consciousness. For example, repeated jerking motion of extremities. Myoclonic, which includes sudden violent muscular contractions. Atonic, that is generalized loss of muscle tone. Next is the epileptogenic zone. Epileptogenesis is the process by which brain develops epilepsy. First zone include ictal onset zone, that is the lesion responsible for the seizure. Next is the epileptogenic zone, that is the area of cortex responsible for the generation of seizures. Next is the symptomatogenic zone, that is the region that generates initial seizure symptoms. Finally, irritative zone that produces interictal epileptiform discharges. Mostly for epilepsy imaging, MRI, we prefer higher Teslas. This is a paper that shows qualitative comparison of 3 Tesla and 1.5 Tesla MRI in the evaluation of epilepsy. In evaluation of epilepsy, the MRI at 3T is performed better than 1.5T MRI in case of image quality, detection of structural lesions, and characterization of lesions. This is another paper that shows that 3T MRI improves the detection of transmantle sign in type 2 focal cortical dysplasia. These are the images obtained from 1.5 Tesla and 3 Tesla, where 3 Tesla image show a blurred thickening of cortex in the right anterior frontal region, which is visible at 3T, but it is not visible at 1.5T. This is another MR image obtained from 0.5T, which is reported to be normal, whereas the same image has been taken in 3 Tesla using a 3D flare, which picks up the cortical dysplasia and delineates the extent. This is the epilepsy protocol used in our department, which include T2 FSC SALS, axial 2D flare, T2 FSC axial, T1 flare axial, 3D flare, oblique coronal flare, oblique coronal T2 FSC, oblique coronal 3D SPGR, 3D ASL, T2 relaxometry, SWI, and DTI. The T2 images are usually taken to assess signal intensity because the hippocampus is normally slightly hyperintense compared with the gray matter on flare images. The 2D flare images which shows cortical and subcortical hyperintensities, which may be subtle. T1 images are usually taken to look for cortical thickness and interface between gray-white matter differentiation. Whereas this oblique coronal is the most ideal plane for depicting the findings of hippocampal atrophy, signal changes, and disruption of internal architecture. Next is the ASL. It is a perfusion technique, which we will be discussing later. And T2 relaxometry will also discuss later. SWI is mainly done to rule out blood products and calcification. Planning for MR epilepsy protocol. First of all, for axial plane, we will cover from vertex to the line of foramen magnum. In sagittal plane, we will plan the line parallel to the ACPC. That is anterior commissure and to posterior commissure. This is a paper that shows that central intercommissural line is reproducible and reproducible reference lines, and it serves as a standard for axial images of human brain. Next is oblique coronal, which we have to cover the whole temporal lobe. The angulation is perpendicular to hippocampus in sagittal plane. In axial, it is perpendicular to the midline of the brain. What is the role of ASL in epilepsy? ASL is a non-invasive perfusion technique. Its main aim is to accurate localization of epileptogenic zone. Whereas the structural MRI help us to detect lesion, and PET and SPECT also help us to detect epileptogenic zone, not lesion. The arterial spin labeling bridges the gap between functional nuclear imaging and structural MRI. The localization principle includes neurovascular coupling mechanism. That is, the regional flow is directly proportional to the regional metabolism. Why we are using ASL? The structural MRI detects the lesion and the ASL detects the epileptogenic zone. In epilepsy, the epileptogenic focus may show hypoperfusion in interictal phase and hypoperfusion in periictal phase. ASL analysis and post-processing, which include structural MRI, and the ASL images will give first a gray scale raw image, then a color CBF map. This is a ASL fused with the structural MRI. Then the color maps and the fusion images helps to demonstrate the anatomic structure. The quantitative assessment of CBF is based on the formula that is proportional to blood T1 and post-labeling delay. The CBF quantification can be done by putting several ROIs over the areas. Its normal value is 50 to 80 ml per 100 gram per minute. It is usually higher in children, whereas lower in adults. Next is enhanced ASL, that is EASL, which uses a multiple delays. The EASL mainly helps us to eliminate artifacts that is due to arterial transit time. It gives both the cerebral blood flow and the transit delay maps. After post-processing, we will get a raw perfusion weighted images, CBF map, transit delay corrected CBF map, and the transit delay map. T2 relaxometry. The measurement of T2 decay time has been shown to be useful in the assessment of hippocampal sclerosis. As we all know, the hippocampal sclerosis is the most common entity associated with the refractory epilepsy. This transversal relaxation mainly occurs due to the magnetic field inhomogeneities and the spin-spin interaction. The hippocampus is a curved structure in the medial temporal lobe. It has a main three regions which can be divided, divided based on the morphology and relationship to the midbrain. The most anterior part of the hippocampal region is the hippocampal head, which is recognized by 3 or 4 digitations on its superior surface. Next is in the center, there is a cylindrical body which extends posteriorly about the midbrain. The posterior portion is a tail of hippocampus that tapers behind the brainstem. This is an image showing hippocampal head with the digitations. This is an hippocampal head, hippocampal body. The most common region of abnormality is the body, and this is an hippocampal tail. Next is DTI. Diffusion tensor imaging. In epileptogenic lesion, the FA values in the subcortical white matter is decreased. So, diffusion tensor imaging helps in preoperative evaluation of fiber tracts during epilepsy surgery, predicting postoperative neurological outcome if lesion is close to the Iliacan white matter tracts. Next is MR spectroscopy, which can be taken as single voxel or multi-voxel. Single voxel will give high SNR with a short time, whereas multi-voxel we can obtain a large volume of information, whereas it takes long acquisition time also. The abnormality typically consists of reduced NAA signal and increased choline and creatine and myoinositol signals. These MRS findings are consistent with the histopathology characteristics of reduced neuron cells counts or neuronal dysfunction and increased glial cell numbers. Role of fMRI in epilepsy, that is mapping the Iliacan cortex, language lateralization, localizing spontaneous ictal activity. The Iliacan cortex is a term that refers to specific brain areas that directly controls the function, and any damage to these areas results in major focal neurological deficits. Application of language fMRI is to identify critically important language areas before surgical removal of tumor or epilepsy and determination of hemispheric language dominance. The paradigms used in fMRI. Paradigms means a sequence of tasks that have been performed by patient during the imaging. Different paradigms include verb generation, semantic decision, syntax, word pair, motor activity, and lip outing. Whereas the verb generation, semantic decision, syntax, and word pair involves language area, which mainly helps in the determination of hemispheric language dominance. The localizing ictal activity by fMRI. It is possible to localize regional metabolic changes accompanying ictal activity by EEG fMRI, which include the temporal resolution of EEG and the spatial resolution of fMRI. The EEG correlated with fMRI has been shown to be a practicable method for localization in epilepsy patients with a frequent intrictal epileptiform discharge. Next is memory fMRI. In case of patient that is in case of patients with drug-resistant epilepsy, memory fMRI is done prior to anterior temporal lobectomy, predicting memory efficiency. There are two types: visual memory and verbal memory. The areas of interest include amygdala, hippocampus, and parohippocampal gyrus. Memory fMRI, which include encoding section and a recall session. To ensure deep encoding, the patients are instructed to analyze whether the faces presented were happy, sad, or neutral in expression, and the word pair presented were in any way semantically related or not, and these designs where it is symmetric or asymmetric. In recall section, we'll be putting this 10 faces along with the 20 distractors. Again 10 words with the 20 distractors. Again 10 designs with the 20 distractors. Next is resting state fMRI. The task-based fMRI may not be appropriate for patients with cognitive defects and aphasia to determine language lateralization. In that case, resting state fMRI can be used as an effective technique to study language lateralization. Even without any stimulation, the ball signal varies due to a number of physical and psychological activities. In the resting state fMRI will map multiple brain functions simultaneously. Then the functional imaging in epilepsy includes positron emission tomography, single photon emission tomography, and magnetoencephalography. The PET will measure cerebral metabolism using radio-labeled tracers, which is useful in MRI epilepsy, MRI negative epilepsy. SPECT measures perfusion, where the localizing value improves with the ictal and interictal subtraction and statistical analysis. Magnetoencephalography localizes the epileptiform generators and is used for the localization of eloquent cortex. Next is the nuclear medicine in epilepsy. It is mainly used for localizing epileptogenic regions, particularly when structural imaging results are normal, when there is discordance between structural and EEG data, and also used when multiple lesions are shown by other modalities, and also used for identifying dual pathology for assessing the presence of potential secondary epileptic foci, and also for the functional integrity of the rest of brain. This is hybrid imaging. The FDG, this is a paper showing FDG PET with the MRI co-registration that improves the detection of cortical dysplasia in patients with epilepsy. This is an image which shows FDG PET with MRI co-registration that indicated a focal area of hypometabolism in the left superior parietal region behind the sensory cortex. Conclusion, this MRI has been widely used tool for the evaluation of patients with epilepsy. With its high spatial resolution, excellent inherent soft tissue contracts, multiplanar imaging capability, and lack of ionizing radiation, MR imaging has emerged as a versatile diagnostic tool in evaluation of patients with epilepsy. With the future improvements in software, hardware, and post-processing method, MR imaging should be able to throw more lights on epileptogenesis and help physicians to better understand its structural basis. Thank you.